Welcome to the Compounding Center Connections podcast, where we talk to different healthcare practitioners about conditions that a lot of our patients are seeing and dealing with. I'm your host, Megan Kilkeary. I'm one of the pharmacists here at the Compounding Center in Leesburg. And today we are partnering with our consulting pharmacist, Jim Paoletti, who has over 30 years experience in bioidentical hormone replacement therapy, in clinical practice as a consultant and as an educator. So Jim, we're going to be talking to you today about different types of hormone testing methods and also some estrogen metabolism. But can you start out and introduce yourself to our viewers and our listeners and tell us a little bit about yourself?
Sure can. I graduated from The Ohio State University way long time ago, back in '76 as a pharmacist. I was involved with compounding to a certain degree, even as an intern in pharmacy school, kind of had a knack for it. So I got involved with Professional Compounding Centers of America, worked as a consultant there for years, went and became educational director for ZRT Laboratories for 5 years, and got on the faculty of the Fellowship of Functional Medicine. Was blessed there to have the opportunity, instead of paying me money to lecture, I asked if I could take the classes. So I am an advanced fellow in functional medicine. I really am blessed in that sense. I've been working on hormones now. This is my 40th year that I've been doing
Wow.
it.
Yeah.
I know I look a lot younger than I really am. So that's my background. I just really enjoy what I'm doing. I am unable to retire.
Yeah.
I just can't stop helping patients because it's just so rewarding that I'm going, like, I told the Lord, if I have the physical, mental strength that you give me to do this, I'll just keep doing it as long as you want me.
Well, I'll let our viewers and our listeners know we've been partnering with Jim for years, and he has been an invaluable asset to us as far as doing consults and helping us interpret a lot of complicated laboratory testing when it comes to hormones. So we're going to get into that a little bit today, and perfect that Jim has a extensive background with ZRT laboratory testing, and we're going to start right into it from there. So Jim, talk to me a little bit about some of the different options for testing and the testing methods that are out there.
Probably the most commonly used is conventional serum testing, or blood draw from your arm where they're getting venous blood. Saliva testing is a possibility. Capillary blood, where you prick your fingertip and collect drops of blood on a collection card, is another method. And of course, urine testing is available. Those are the 4 types of testing that are used.
Great. When do you recommend using one test versus another for a patient?
Well, we'd have to talk test by test, pros and cons. So where do you want to start? Which type of test do you want to start with?
Yeah.
Conventional serum testing?
Yeah, I think probably most of our patients that go to their, practitioners to, have their hormones checked are probably steered in the direction of serum testing. So let's start there and tell us what you think about that.
Pros and cons. It is covered by insurance in most cases. It is accepted as a gold standard. Doctors are very familiar with what can be tested. Those are all good. There are some disadvantages. Once you're on hormones, that may not be the best route to check. For instance, if you are using a topical hormone, it is not going to show up in the venous serum. The venous serum is the waste system or the sewer system of the body. It's to eliminate waste and excess. So putting something in the body that belongs there, that's normally metabolized in the body, it's not like a drug where you're trying to eliminate it because it's a poison, it's a foreign substance. You're going to use that up, metabolize it. It should not be seen in any great quantity in the venous serum. Same thing with vaginal application. It's going to show up some, but not to the degree that's going to help you adjust dosages. So if you're on those forms, it's not going to work. If you're on an oral progesterone, the progesterone level would work in that case. That's one of the limited ones that you're actually on a hormone that the serum can be used. If you're not on hormones, serum can be used, but there's a little reservation on my part there. Most labs still use the same process for measuring testosterone and DHEA that was developed for males. It is not sensitive and accurate enough for females. And I can prove that by the simple fact that If you take one of the larger labs, their normal range for testosterone in women is 14 to 76.
Mm.
For every woman from puberty to death. Testosterone levels do not stay the same your whole life.
Mm-hmm.
And therefore, I need to know when I test your testosterone, where are you compared to the average person your age, and where are you compared to the average 20 or 25-year-old when your testosterone level is optimal? I can't answer those questions if your lab range is the same for all ages.
Mm-hmm.
So, the reason that occurs is because it's not a sensitive test. They can't do what should be done and give age differentiated ranges. In other words, here's your average range for 20 to 29, 30, 39, et cetera. So it's hard. Now, if you did a testosterone, you came back really low, yeah, you're low. But if you're not, if you're somewhere in the first third or half of that range, I can't tell you where you're at.
Right.
And DHA, not as bad, but same thing. You're looking at one normal range for all adult women. Makes it very difficult to interpret.
Mm-hmm.
So, but I can use it for progesterone and estrogen if women are not on those hormones.
Mm-hmm. So that'll lead us into our hormone patients, where we generally recommend saliva testing as the best method of testing. And I know from working with you, you have an extensive background, in saliva testing. And so talk to us a little bit about saliva testing and why you like that and the pros and cons of it.
Yeah, one of the real advantages that, if I could somehow stick a needle or take a laser and point it somewhere in the body to measure a hormone, I would go right to the tissue where the hormone receptor is, right where the active hormone works, and I would measure the active form, the free or unbound form. Mm-hmm. When you do like serum testing, you're looking at the total, free, right, the bound and unbound put together, unless they specifically order a free hormone, which is seldom done. Saliva, you're looking at a representation of the free hormone in the tissue. Wow, that's the active form where it works. That's the best measurement. How's this hormone getting to your tissue receptors where you need it? Mm-hmm. Okay. Other advantages are with saliva, I can measure cortisol throughout the day. And if you have adrenal issues, you need a good measurement of cortisol throughout the day to get your cortisol output pattern. And you can only do that if you're doing urine or saliva. You cannot do serum. First of all, serum only does it once or twice a day. And their normal range in the morning is over a 2-hour range. Cortisol changes so much in the first 2 hours. I'm going like, everybody's going to be normal. That doesn't help me. Right. With ZRT saliva, for example, they'll graph it out. They show you exactly where the cortisol should be every half hour. And your results are plotted according to what time you tested. So you know exactly where you're at. So it's a clear-cut picture. The disadvantage of saliva is sometimes people have a hard time collecting saliva. Mm-hmm. Estrogen syndrome, something like that. And if you have any bleeding disorders, gum bleeding disorders, you cannot get any contamination of blood in there, or it throws your levels way off. There's so much more hormone in the blood than there is in saliva. I know at ZRT what they do there, the people who examine the package when they open it up, if there is a slightest trace of pink color to that saliva, that's it. They can't test it. Tell you right then, no, we need to go a different route or clear up whatever causing the blood disorder first. So that's a disadvantage.
Sure. What about for patients who are using like an oral form of their hormone, like in a troche form or like a sublingual drop form? Is the saliva testing an issue for them?
Good point. Oral capsules are okay, but if you're holding the hormone in your mouth for buccal or sublingual absorption, whether it's a troche, lozenge, drops, you're going to get a local buildup of that hormone. So you can't test that hormone. Now, you may be able to test other hormones, but I just recommend in general, if you're using a buccal or sublingual administration, we're going to go a different route, most commonly capillary blood.
So the third method of testing that you mentioned was urine. So when do you like to use urine testing, or do you use it at all in your patients?
I do use it, but not the way other people are using it. Urine testing is looking at metabolites, not the actual hormone. So if your baseline, you're not using any hormones, urine will show me whether you're deficient or not. Measure the cortisol, so it can give me the same information a saliva test would do. I don't use urine because it's usually $100 to $150 more for the same test. I'm
Mhm.
not getting any additional information. Now, other people say, well, you're getting the estrogen metabolites to see if they're safely metabolized, and we'll talk about that later. I don't
Mhm.
agree with measuring metabolites before you're taking estrogen if you're deficient, because your ratio you produce the metabolites may vary once you're on it. So I like live up front. It's less expensive. The patient gives me the same information. But urine is very useful for other aspects. If you want to measure your iodine, if you want to measure your neurotransmitters, you want to measure
Mhm.
heavy metals, excellent job on those. And I use
Mhm.
PRT neurotransmitter profile a lot and has had some great results using it.
Mhm. Yeah, great. When should a person, male or female, um, seek out hormone testing? You know, in like a perimenopausal state, should they wait till they're in menopause, postmenopausal? When do you normally recommend, a person to do testing?
Ideally, when they're 25 and everything's great and they're balanced, uh,
Get a
I
baseline.
yeah, I had my daughter. I made my daughter a deal when she went to college. I'm going to pay for your education as long as two conditions: nothing lower than a B, and you got to spit for me 3 times.
Yeah.
I want over the next 3 years. I want 3 saliva tests. Now, when she becomes perimenopausal, she doesn't have to go, here's the general range that you should be in. No, here's your number.
Yeah.
Exactly. So in the ideal world, yeah. And I've told a lot of my patients who have offspring, yeah, get your offspring tested now while everything's good. Okay, at
Right.
least
Right.
once. But no, for general purposes, when women get into perimenopause, as soon as they start showing symptoms. Now, as far as what testing they should do, that varies. I tell people the first thing I would have to do is fill out our health questionnaire, get
Mhm.
that to me, let me look it over. Instead of saying what a general person, the average person your age should test, let me look at your specific situation, what's going on with you, and I'll recommend testing for you. There are
Mhm.
cases where we don't have to measure everything. Okay. So I like
Right.
to individualize it. But anywhere in that, as soon as you start, if a woman starts having irregular cycles, time to check. If she start having symptoms of hormone balance at 32 and 38, yeah, check then. Now, we may not check the same things. I've had a lot of patients this past year between 20 and 35. And most cases, it was either stress and or neurotransmitters. Nothing wrong with their estrogen and progesterone. So again,
Mhm.
once I looked at health evaluation, I determined what they have to measure and how best to measure it. But I always talk options with patients.
Right. How often do you like to recommend someone have testing done? Yearly?
We mean once they're on hormones.
Yeah.
In most cases, most physicians that are prescribing the hormone, that agree to my recommendation, they're going to want a follow-up test, and they vary. Some of them 6 months, sometimes a year, sometimes 2 years. But sooner or later, they're going to want to make sure that you have physiological levels. I have no such requirement,
Hmm.
but I've been doing this 40 years. I tweak a lot of dosing based on what symptom response.
Right.
I get stuck sometimes. I'll say, okay, we need to retest. Uh,
Hmm.
but for the most part, I don't have a set requirement. But honestly, a lot of patients, they want to see their test results sometimes 6 months or a year in. They want to see where their levels are. So
Right.
most of the time, I'm just guiding patients on what tests to do. They or their doctor decide when to do that first follow-up test.
Hmm. If you are already on hormone replacement therapy, is there anything that you should stop or know about prior to, taking to retesting?
Yeah, I have a lot of patients that get confused on that. That's an excellent question. No, you don't want to stop your hormones. That would be like if you're going in to see your doctor and you take a blood pressure medication every morning, you're going to go in and he's going to take your blood pressure. Would you skip your dose that morning?
Right. Absolutely not.
Medication's working. No, absolutely not. You're going in to measure your thyroid. Do you skip your dose that morning? No, it's not going to show the level that you get every day from it. So what I
Right.
want, if you're already on hormones, for the most part, in general, I would say I want to see where your levels are from what you're on. Now, sometimes if they're on excessive hormone and I know it to begin with, I will actually taper them down on the hormones for a while, maybe a month,
Hmm.
6 weeks, and then have them test. But I always
Hmm.
want them, if they've been using hormones, to be on the hormone. But I like to go over specifically with them, when to do the last dose before you test, collect your saliva or capillary blood or whatever. Um, and make sure they're doing it right. So, but I do that on an individual basis. But yeah, stay on your hormones.
Yeah. Anything that you want to finish up? Where we're going to move on to our next topic about
Well, I want to
estrogen
mention the
metabolism.
capillary blood testing, since we've mentioned it a couple of times. We want to talk the pros and cons of that.
Yeah. Oh, okay.
Capillary blood is, again, it's a blood spot collection. You prick your
Right.
fingertip and put drops of blood on a card, let it dry. It's perfectly stable. The advantage of that is when you're using a sublingual dosage form, capillary blood represents the blood that's taking everything to the tissues normally. Nutrition, oxygen, hormones. So you're measuring it on the way to the tissue. So it's a good representation of what hormone gets to the tissue. Doesn't really good job of that. Its advantages are there's some things we can check in blood that you cannot check in saliva. Larger proteins like thyroid, vitamin D. If I have a male and I'm considering testosterone replacement for this male, I want to get a baseline PSA and hematocrit because those have to be monitored. Right? You can do that spot. So the blood spot offers a lot of advantages. I think you're going to the number of things that they're testing in capillary blood keep increasing every year. I think in a few more years, you're going to see this more commonplace where people are just going to be pricking their finger at home and testing all kinds of things. I just did a cardiometabolic risk profile and blood spot. It's fantastic. It looks at all these risk factors. Why? Well, I'm now older than my father lived to be, and either one of my grandfathers, all three of which died of heart attacks. So I thought maybe I ought to look at those risks.
Oh yeah.
So there are certain things you can test, but as far as hormones goes, the real advantage is if you're on a sublingual dosage form. The disadvantage, you got to be careful. If you touch that hormone cream that you're applying against your fingers at all,
right,
you can have that hormone in that tissue for up to 7 days. So I always tell people, if you're using a topical and you go capillary blood, always put latex gloves on, or non-latex gloves if you're allergic to it, before you open that kit up and start handling things. Because you can get that hormone on the edge of that tube, and next thing you know, you've got a contaminated sample. So that's like one disadvantage there, but you can work around that.
Right. I will tell our viewers and our listeners, if you're local here to us in the area, we do stock saliva and capillary blood tests here through ZRT Laboratories. That's our preferred method of testing. And as I mentioned earlier, we partner with Jim. And so that's what he helps to interpret for us in our patients. So if you're local to us and you're interested in this kind of testing, feel free to stop into our pharmacy at any time and pick up a saliva or blood spot test kit from us. And we can guide you through a consultation process from there. So the other thing, Jim, in the last few minutes that we have that we wanted to talk about was a little bit about estrogen metabolism. I know we have a lot of women that come to us that are nervous about starting hormones. They have breast cancer risk in their family, and so they're hesitant. So talk to me a few minutes about helping the practitioner and the patient determine, how estrogen is metabolized and kind of allay their fears a little bit when it comes to being on hormone replacement therapy with regards to breast cancer.
Well, first, I have to say that what I do, balancing bioidentical hormones at physiological levels, has been done in Asia and Europe for 50 or 60 years, and there's not a single report or study in all that time that shows it increases the risk of breast cancer. Breast cancer risk is due primarily to the improper way we've done estrogens in conventional therapy in the U.S. That said, every woman, including you, Megan, makes bad estrogen metabolites, or catecholphenones that can damage DNA and initiate cancer. And that's how hormonal cancers are initiated. The really good thing, it's a minute percentage. It's somewhere between 0.01 and 0.1% of your estrogen metabolites go down that pathway. That's it. You always want to keep it at that very, very low percentage. There are a number of things you can do nutritionally, lifestyle, as far as avoid trans fats, avoid activating lipid peroxidase, et cetera, lack of iodine. There's a number of nutritional things. In fact, if a woman's concerned with breast cancer, I'll give her a copy of my chapter on safe estrogen metabolism from my book and say, read through this. And then everybody has to decide how far do I want to go. I could give you at least a dozen things, lifestyle and nutritional supplements you can do steer that to safe estrogen metabolite. Let's steer it to conjugation. Let's steer it to methylation. Let's steer it to all the processes that exist in the body that safely metabolizes it. That's easy to do. Okay,
Right.
so there's things like estrol, E3. I use that in a lot of women. They're now studying estrol to treat women to prevent reoccurrence of breast cancer, and they're now looking at it to treat breast cancer. It's actually been compared to tamoxifen in a study and showed equally effective. So we're learning more all the time, but I don't get hung up on this 2OH, 16OH ratio. I'm sorry, that ignores the most important thing. What's your 4OH? If a woman is concerned, I will say, look, let's get you on the estrogen for at least 2 weeks, if not 3 or 4 weeks. Now let's measure urine metabolites and see how you're metabolizing it. We'll tell you if you make too much of the 4OH, and then we'll go deep on how to change that. Other women choose just to go ahead and take at least, some resveratrol, green tea extract, NAC. There are some nutrients that have shown very beneficial in preventing the formation of the 4-catechol-quinone. So there's a lot we can do to decrease it. But I think the most important thing is start with a therapy that doesn't increase your risk.
Right. Absolutely. Yeah. I think the big message that, we want to convey to women is that, hormone replacement therapy does not cause breast cancer or does not cause, any other, or increase your risk of any other types of cancer. As Jim was saying, there's the new research that's out there now is showing that it's, potentially used as treatment now and helping to ward that off. So, please don't let that scare you off, from considering hormone replacement therapy. Jim, anything else we should know about as far as estrogen replacement?
Not this time, just as estrogen is, by the researcher Cavallari termed it this way: estrogen is the angel of death, estrogen is the angel of life. In other words, it has so many protective benefits. It works together with progesterone, protecting the brain, the heart, the cardiovascular system, the nervous system, the bone. It's wonderful if you don't do it wrong.
Right.
Done incorrectly, now it increases your risk. We don't go there.
Right. Absolutely. Well, I think that's a great way to end this segment with you. So thank you for your invaluable insight into these topics. And for those of you who are tuning in, stay tuned. We have several more topics that we're going to be discussing at later dates with Jim Paoletti here. And if you have any questions, please feel free to reach out to either one of us. We'll provide both of our email addresses at the end of this presentation. And thanks for tuning in. We'll see you next time. Jim, thanks again so much.
Thank you, Megan.